Good morning. Then we'll talk about CNS infection in immunocompromised patients. Then I acknowledge the help by my colleague, Professor Sylvie Grand. And then, what about immunodeficiency, actually? It requires, usually I will deal only with adult subjects, not with children. And most of the time it's acquired. And one of the main causes HIV infection, diabetes, and also iatrogenic related to cancer treatment, transplant, or systemic disease, and even now multiple sclerosis. To try to cover, it's a kind of list in a certain ways, and we'll deal mainly with several infections, with bacteria, nocardiosis, for instance. We won't deal with tuberculosis because we'll refer it in immunocompetent patient too. Viruses like HIV or JC virus or cytomegalovirus. Parasite, toxoplasmosis, fungi, aspergillosis, mucormycosis, or cryptococcosis. And of course, all immunodeficient patients may experience all common infection, of course. What about bacterial infection? I will only deal with nocardiosis. Nocardiosis is an ubiquitous bacteria involved by lungs, and the spread is heterogeneous. And then you'll have some abscess into the brain, very similar to the miliary tuberculosis. Little abscess all over the brain with distribution in the deepest area and also superficial area. And I mean, the presentation of this disease is not specific, but it's quite suggestive. This heterogeneous spread of nocardiosis with tuberculosis and other germs. Viral infection. When you deal with immunocompromised patient, sometimes it's related to HIV. It's quite important to recognize CNS disorder related to HIV. Clinical presentation is mostly referred by cognitive decline, sometimes behavioral disorder. Motor function is rather rare. Usually it occurs at the immunodeficiency onset, and it consists in white matter lesion. I hope that you see this subtle white matter here lesion, very close to ventricles, here and here. Usually it's diffuse, symmetric, and it's imply a very highly active antiretroviral treatment. Here's another example. On T2 or FLAIR, you have these bilateral hyperintensities here, rather periventricular. It says that it spares the U fibers and the fiber below the sulci, but it's not exactly true. In this case, or in other case, we'll see in the workshop, we'll see that sometimes the U fiber are involved as well. What you have to keep in mind is that those lesions are rather periventricular. They do not enhance. You don't see nothing on the diffusion imaging, and on T1 you don't see a real dark lesion, as we can see in JC virus infection. Then remember, this bilateral symmetric periventricular lesion are quite suggestive of HIV encephalitis. A more difficult, a more aggressive disease is a progressive multifocal leukoencephalopathy called PML. It's due to JC virus, and it's a demyelination which is rather focal, in this example. It occurs in patients having HIV, but not only. And now, while we use chemotherapy and even immunodepressant treatment, you may observe this kind of disease in a large variety of patients under treatment, like multiple sclerosis too. The clinical presentation is not so specific, but when compared to HIV encephalopathy, you may have some focal deficit, like motor deficit, for instance, diplopia or hemianopia, or even seizure. As a diagnosis is done, usually we have CSF analysis where you reveal the GISF virus. And here on the imaging, what you see is a rather multifocal hyperintense lesion. You see rather bilateral. It can be bilateral, but not symmetric. It's rather asymmetrical. And what is really stunning is the hypointensity on T1. This hypointensity on T1, this subcortical hypointensity on T1 is very suggestive. I mean, actually, the lesion usually involve the U fibers, and you see this subcortical lesion here with a very dark hypointensity on T1. It does not enhance, actually, most of the time, but we revealed that in patients under treatment like multiple sclerosis, it may enhance, you may have some foci of enhancement. On diffusion, you don't see so many things. Sometimes you can see a peripheral rim of demyelination, and on perfusion, there's no, except a decrease of the CBV, of the blood volume, so there's no typical feature. Sometimes, once these patients experience these PMLs and this progressive multifocal leukoencephalopathy, once you treated them and the immunity recovers, then you will have a quite aggressive response against the lesion. And this is at the beginning, before treatment, and after treatment, you may have a real inflammatory response with an increase of the size of the lesion, like on this example here on T2, and an increase of contrast enhancement, or it may appear when it was not present at the beginning. Then it's called the IRIS for immune reconstitution inflammatory syndrome. Then it's quite well known now that when you start treating this patient with quite aggressively, you may experience this PML iris. Then this reveals the reconstitution of the immunity. The third virus we would have to deal with would be the cytomegalovirus. It's a very common virus. Present in most of the population, and in healthy subjects, you don't experience any disorder. But when you have in immunocompromised patient, it may become pathogenic. All the CNS can be involved, could be the brain, the cord, and of course the optic nerve. And it's quite common that the retina is involved by the cytomegalovirus. The clinical presentation is absolutely not specific. Usually a cognitive decline or headache, focal disorder are rare because you rarely have focal lesion. You'd rather have periventricular abnormality, like here you see an ependymal enhancement. Here is on diffusion, you have an increase of signal around the ventricles. On T2, you have also hyperintensity around the ventricles, and it can be a very subtle, subtle enhancement on T1 post-contrast. Now let's move to the parasites. And the most common parasite involving immunocompromised patient is toxoplasmosis. Most of the population, I mean, at least maybe half of us would have already have this infection. It's latent in immunocompetent people, usually, especially when you have cats. Then you may find their eggs eaten by pigs, and when you eat pigs or goats or even vegetables and fruits, you may have this infection. Usually it's not a problem except for pregnant women, you know it, and for immunocompromised patient. And for immunocompromised patient, you will experience focal lesion like little abscess. It can be unique, are multiple, usually involving the deepest area of the brain, but not always. It's not constant at all. Then the lesion on T2 or FLAIR, for instance, on FLAIR you may have a central hypointensity surrounding by a hyperintensity like an edema. On T1, quite similar, you may have a central hypointensity surrounded by contrast enhancement. You see a peripheral contrast enhancement with a little particularity here, a small enhanced center. Then it's called a target sign. But the fact is that this little central enhancement is not in the middle of the target, but a bit on the side of the target, and it has been called eccentric target sign. On diffusion, imaging is not always helpful, especially when you have, it can be restricted, but not always. On perfusion, it's, you don't reveal any hypervascularization, and on spectroscopy, you may have a very high lipid peak. Then here are the two most common morphological features of toxoplasmosis. First, on T2, what's called the T2 concentric target sign, with a dark center, high signal rim, and another rim with a milder signal here. And on T1, which is much more suggestive, the eccentric target sign, it's on T1 post-contrast. You see then the darkest content of the central part of this little abscess. And into this content, you have a little enhancement like a small target. And out, again, you have a peripheral rim of enhancement. Also another striking feature is after treatment, you may observe a spontaneous hyperintensity on T1 before any contrast injection related to lipid storage. And last, we'll finish with fungal infection. Then fungal infection is a very common disease in immunocompromised patient, and you have a large, many different fungi that can be involved. Let's say that one of the most common are aspergillosis, mucormycosis, and cryptococcosis. The other one also are possible, but quite rare. One of their common feature is that those patients, they don't come to see you spontaneously with fungal infection of the brain. Usually they have a very, very poor condition. They rather are in intensive care. And of course, they will have a meningitis, but which is really not specific. And but what is really striking is all those deep brain lesions. And it can also be associated, and it's often associated with vasculitis and infarction. So here is a case of aspergillosis. What is really striking is that it's following all the roots of the vessels, and you may have also abscess and stroke in the deepest part of the brain. You see the hyperintensity involving the basal ganglia, the capsules around the ventricles. On diffusion imaging, you may have an increased signal related to a lower restriction of the diffusion. On post-contrast imaging, you will have incomplete enhancement of the periphery of all this little lesion. Then it's a mixture of abscess, necrosis, and also of stroke. Since we have quite reliable susceptibility weighting image, we now see very clearly this little hypointensity, peripheral hypointensity, which are quite suggestive of fungi. You see on the SW high, this little hypointensity, very, very suggestive of fungi. And the cryptococcus is quite a bit similar, maybe not so aggressive. Anyway, you may have leptomeningitis, as it's the case here, related with hydrocephalus. This is a major problem, and sometimes it can be an emergency. And you also have a spread along the vessel and the perivascular space involving the basal ganglia. You see here the putamen, the caudate involved by the lesion. You see on this case from the internet, this little spontaneous lesion in the basal ganglia with a small hyperintensity, spontaneous hyperintensity on T1, very mild enhancement, and on T2 this very suggestive image involving bilateral basal ganglia. Then remember, in any case, especially dealing with neuroradiology and radiology in general, but especially when you have this immunocompromised patient, you have to take into account the patient history. It's very important, and to have the maximum of clinical and biological data. Among quite old challenge was the differential diagnosis between HIV and JC virus infection, progressive multifocal leukoencephalopathy. Both have white matter lesion, and some for HIV are rather periventricular, while for PML they are rather subcortical. For HIV they are diffused, while for PML they are scattered. HIV are symmetric, while PML are asymmetric. On T1, HIV lesion are ISO. It's very hard to see them. They have an ISO intensity, very hard to see them. But for PML, the dark hypointensity on T1 is very, very suggestive. Contrast enhancement won't really help you because it's very inconstant in PML. And the diffusion is not always helpful. Sometimes you may have a lower rim of low assay of restriction in PML. And remember now, PML is not only related to HIV. Now you have PML in patients treating for cancer or even multiple sclerosis. And when you start to treat the PML, you may experience this reconstitution of immunity giving high risk. When you have a ventriculitis, it's really non-specific, but remember to the cytomegalovirus. Toxoplasmosis is the most common infection in HIV patients, and remember the target signs, concentric, especially eccentric target sign on post-contrast enhancement. And when you have deep brain metal lesion, always consider a fungal infection, especially when you have a very poor condition. You may experience this vasculitis with stroke, and SWI can be very helpful to demonstrate these microbleeds. And finally, I recommend you as a protocol using MR. I mean, CT won't really be helpful. If you really want to characterize this lesion, you need an MR. You need at least a non-enhanced T1, diffusion imaging, SWI or T2 star, and post-contrast 3D flare and 3D T1 with turbospinaco. Optionally, you can perform TOF imaging or black blood imaging when you suspect vasculitis, and spectroscopy can be quite interesting in demonstrating lipids, for instance, in toxoplasmosis. An excellent reference, brand new, you can have a look at. Thank you for your attention. Do you have any question? Or we move to the workshop right now?